Your pharmacist just handed you a white paper bag with 6 orange bottles in it. You didn't count them. You never do. You just say thank you and go home. But what I'm about to tell you might change the way you look at every single one of those bottles. Because after 22 years of practicing geriatric medicine, I can tell you this with absolute certainty. Some of the medications your doctor keeps refilling year after year are more likely to hurt you now than they are to help you. And most doctors will never bring it up unless you ask. I'm Joshua Smith. I've spent my career helping patients over 65 figure out which medications on their list are still earning their place and which ones are just sitting there, quietly doing damage. And today I need to share something that goes against almost everything you've been told about taking your medicine like you're supposed to. There are 5 medications that I take almost every one of my patients off of once they cross 75. Not because I don't believe in medicine. I do. But because I've watched what happens when a pill that made sense at 55 keeps getting refilled at 85 without anyone ever asking whether it still should be. Before I walk you through each one, you need to understand something that changes everything. It's called the medication math, and it flips on its head after 75. When you're 55, most medications make perfect sense. You start a statin, it lowers your risk of a heart attack 10 years from now. You have 10 years to collect on that investment. The math works. But after 75, 3 things change. First, many medications take years to pay off. And if your remaining life expectancy is shorter than that, you're absorbing all of the side effects and none of the benefit. Second, your kidneys and liver clear drugs more slowly. So a dose that was safe at 60 can quietly build up to a toxic level at 85 without anyone changing the prescription. And third, there's something we call the prescribing cascade. A medication causes a side effect. That side effect gets mistaken for a new medical problem. That new problem gets its own medication. And that medication causes its own side effect. I've watched this cascade turn a healthy, independent 80-year-old into someone falling down, foggy, and on 8 pills before anyone stepped back and asked what started it. That's not good medicine. That's harm wearing a lab coat. Now, let me walk you through the 5. Number 1, long-term daily use of acid reflux medication. I had a patient named Dorothy, 79, from outside Sacramento. She'd been on omeprazole, the little purple pill, for 12 years. It started for occasional heartburn after a stressful year at work. She never stopped taking it, and neither did any of her doctors, because it was easy to just click refill. Dorothy came into my office after a fall in her kitchen left her with a broken hip. A bone scan showed osteoporosis far more advanced than her age alone would explain. Here's the thing. The American Geriatric Society's Beers criteria, the guideline most geriatricians use to flag medications that carry outsized risk in older adults, specifically calls out long-term proton pump inhibitor use. Beyond 8 weeks, unless you have a specific high-risk condition like Barrett's esophagus or you're on chronic steroids, the guidance is to reassess the medication every single year. Years of continuous use have been linked to lower bone density, fractures, C. diff infections, and vitamin B12 deficiency. If you've been on one of these for longer than a few months and nobody has asked why lately, that's worth a conversation. A lower dose, an as-needed schedule, or a different class of medication entirely might get you the same relief with a fraction of the risk. Number 2, statins for patients who are frail or have a limited life expectancy. This one is going to be controversial, so let me be precise. I am not telling anyone with heart disease to stop their statin. I'm talking specifically about older adults who are frail, living with advanced illness, or whose life expectancy is measured in months rather than years, who are still being kept on a statin that was started decades ago for prevention. Here's what the research shows. A randomized trial published in JAMA followed patients with advanced illness who were taking statins purely for prevention and found that stopping the medication did not shorten their lives, but it did improve their quality of life, with fewer muscle aches, less fatigue, and 1 less pill to manage. I had a patient, Walter, 83, a retired mechanic. He'd been on a statin since he was 55. By the time I met him, he had advanced heart failure and moderate dementia, and his daughter was still dutifully refilling a prescription meant to prevent a heart attack 20 years down the road he no longer had. He complained constantly of muscle pain that made it hard to walk to his own mailbox. We stopped the statin. Within 2 months, he was walking further and complaining less. If you or a loved one is frail and has been on a statin for years, purely for prevention, ask your doctor honestly, how many years does this need to work before it pays off? And do we realistically have that much time? Number 3, tight blood sugar control in patients who are frail. This one sounds like it should always be a good thing. Lower blood sugar, less diabetes damage, right? But tight glycemic control in a frail 80-year-old is a different calculation than it is in a healthy 55-year-old. Large clinical trials have shown that pushing an A1C down to under 7% does not reduce cardiovascular events in older adults, but it does significantly increase the risk of severe hypoglycemia, dangerously low blood sugar that can cause confusion, falls, seizures, and even death. That's why the American Geriatric Society now recommends a relaxed target, often up to 8%, for older adults who are frail or managing multiple chronic conditions. I had a patient, Helen, 84, living alone in Arizona. Her sliding scale insulin dose had never been adjusted as her appetite and weight declined with age. Her daughter found her unconscious on the kitchen floor one morning. Her blood sugar had dropped low enough to cause a seizure. She survived, but she spent 4 days in the hospital for a target that was never appropriate for her in the first place. If you or someone you love is frail and being treated toward a very tight blood sugar number, ask whether the target has been reassessed in the last year, and specifically ask about the risk of lows, not just the risk of highs. Number 4, benzodiazepines and prescription sleep medications. These are the drugs like lorazepam, diazepam, and zolpidem, sold under names like Ativan, Valium, and Ambien. They're commonly started for anxiety or insomnia, and they are, without question, one of the most dangerous classes of medication for older adults, according to the Beers criteria. They slow reaction time, impair balance, and increase the risk of confusion and falls. I had a patient, Frank, 88, from a suburb of Chicago. He'd been taking lorazepam nightly for over 15 years, prescribed originally after his wife passed away. One night, he got up to use the bathroom at 2 a.m., lost his balance, and fractured his hip. Here's what most people don't know. Roughly 1 in 4 adults over 80 who fracture a hip die within the following year, not from the fracture itself, but from the cascade of complications, the surgery, the immobility, the pneumonia, the loss of independence that follows it. Frank's fall wasn't random. It was a predictable consequence of a medication that should have been tapered years earlier. If you or a loved one has been on one of these medications for months or years, please don't stop it abruptly. That can be dangerous on its own, but do ask your doctor about a slow, supervised taper and safer alternatives for sleep and anxiety. Number 5, aggressive blood pressure control with multiple medications. This is the one that worries me most, because on the surface, lower blood pressure sounds like an unambiguous win. And in a healthy, active 70-year-old, tight control genuinely does reduce strokes and heart attacks. But in a frail older adult on 3 or 4 blood pressure medications stacked on top of each other, the target itself can become the danger. Standing up too quickly with blood pressure pushed very low can cause a sudden drop when you rise, dizziness, and a fall, a condition called orthostatic hypotension. I had a patient, Ruth, 91, from coastal Oregon. Her blood pressure had been aggressively managed down to a number appropriate for someone decades younger, using 4 separate medications. She stood up too fast one afternoon, blacked out, and struck her head on the corner of her kitchen counter. The subdural bleed that followed left her with permanent cognitive changes she never recovered from. The treatment meant to prevent a stroke caused a brain injury instead. If you're on multiple blood pressure medications, ask your doctor to check your blood pressure both sitting and standing, and ask whether your target has been individualized for your age and your fall risk, not just pulled from a chart built for someone 40 years younger. Now, I promised you something practical. So here are 4 questions I want you to memorize. Write them down. Bring them to every single appointment where a medication is being started, renewed, or refilled without a second thought. I call this the 4 questions protocol. Question 1, what was this medication originally started for? And is that reason still true today? Question 2, if we lowered the dose or stopped it, what would we watch for? And how would we know if that was safe? Question 3, how many years does this medication need to keep working before it actually pays off? And realistically, do I have that much time? Question 4, is there a lower dose, a different approach, or no medication at all that gets me most of the benefit with less of the risk? Any good doctor will welcome these questions. If your doctor brushes them off, that tells you something too. I want to be very clear about one thing. I am not telling you to stop your medications. I am not telling you to skip your insulin or throw away your blood pressure pills. If a medication is actively controlling a real problem right now, keep taking it and talk to your doctor before changing anything. What I am telling you is that a medication started 15 years ago, for a reason nobody has revisited since, deserves a second look. That review, the one where someone actually asks whether this still makes sense for you today, is different from blind, automatic refills. And you deserve that review. For 22 years, I've watched patients walk into my office on medication lists that grew one refill at a time until nobody, not even them, remembered why half the bottles were there. Not because any single doctor made a mistake, but because the system is built to keep prescribing and rarely built to ask when to stop. You have the right to ask why. You have the right to understand the risk of staying on something just as much as the risk of stopping it. Your medication list, your choice, your life. If this helped you look at your own medicine cabinet differently, subscribe to this channel. I make videos like this every week to help you make informed decisions about your health after 60, and leave a comment below. Tell me, has a medication ever caused you or someone you love more harm than the condition it was supposed to treat? I read every single comment, and your story might help someone else ask the right question at their next appointment. I'll see you in the next one.